I'm Dr. Ariel Polanca, and you're watching The Step. Well, welcome to The Step, Dr. Picascio. How are you today?
I'm good, Ariel. Thank you for having me.
I'm guessing you are in your basement in Chicago area?
Yes. The basement, 60 miles west of Chicago, where I grew up. So maybe the Ditka jersey is a giveaway.
That was a bit of a getaway. How are you today?
This is good. This is kind of the the area where I can get away from the kids and maybe not be disturbed. So here we are. Good. It's a hot day here, so we did a bunch of stuff. Took the kids to the pool, and then I got back for this. So we're gonna round it out. It's gonna be a nice Sunday.
Well, thank you so much for joining us. We really, really appreciate it.
My pleasure.
You are going to be the part of our social media edition. So we're going to be just talking about you and I as surgeons and sort of how social media plays into our practices and just sort of our philosophies and what we are doing with them currently. So if you wouldn't mind, we've talked about this a little bit before, but just sort of how you got involved with social media and how it's affected your practice.
Oh man, it's a really funny question because I'm really not known for my social media prowess in my inner circle. As a matter of fact, many jokes are made about my technical skills and my abilities with computers and iPhones and all that stuff. I really my practice before I sold it and joined Ortho Illinois was very niche. So I'd been here long enough. I'd gotten set up before a lot of the Affordable Care Act stuff started consolidating all the big primary care referral sources and things. So I went around and it was back in the day when you picked like a name for your practice that would get you to the front of the yellow book pages. So that's sort of how I started. And fortunately, by the time social media became something that I think is important for young doctors, I had already been pretty well established. So I never took too much time or energy to get into that. I started doing social media, and by that I mean LinkedIn, because I do not have a Facebook account or a X account or any of that stuff, or Instagram. One of my fellows, Shamim, who's now in Detroit, he called when he was considering doing the fellowship, and I told him in about an hour and a half conversation, this is what the fellowship is. You're going to work really hard. These are the types of cases we do. We do a lot of it, and you work quite a bit, but I've heard the feedback from my fellows is that it's worth it. It's a year that's worth kind of putting in the extra work. And he was about 3 months into the program. He said, "Wow, he's like, I didn't really believe you that you did all these cases and you did that much of it." And he said, "You really need to start posting this stuff somewhere so people can see it." And I'd never given it that much thought. And so this is, of course, a younger doctor coming in who's very familiar with iPhones and technology. These guys are 20 years younger than me. And so he showed me how to do it, and it was pretty funny because like one time I like took a video of a video and said to him, "Can you figure out how to post this?" So the social media expert, not really, but I did it to try to highlight the fellowship and improve and just increase the bucket of applicants, sort of the we want to cast a wide net. And he said, you really need to let more of the residents and more of the programs out there know what we're doing here, because everybody knows all of the big programs that have been around for a long time, and our program is now pushing about, with me particularly, about 10 years, about 7 years with Dr. McEnany. And so that's how we started doing it, and it actually worked. I mean, we really started just putting cases up, and I would put a case up and say, "Hey, if you want extra training, you want to learn how to do this, consider this fellowship program, the Northwest Illinois Foot and Ankle Foundation Fellowship." And overnight, our application pool got bigger, and the quality of the applicants was good. We'd always get several good candidates to choose from, so we're lucky that way. But now it's actually become quite competitive, and that's really how I got into the space of just being on LinkedIn. And then it became sort of this community of docs who, and there's a bunch of them who regularly communicate back and forth and tag each other and put cases up. and it's quite a bit of fun because we use it now as an education tool. Some people use it as a, hey, I got this tough case. It's a instant second opinion by some of the top people in the field, some of the top people that are in LinkedIn and doing that, and so you get a lot of good feedback from those guys, and that's really how it's evolved. So never really set out to be a big social media person, but wanted to sort of just get the word out on the fellowship, and then that just morphed into what it is now.
And are you the one that's managing the page, or do you have someone doing that for you?
Oh, I manage it, and that's why anybody who is on LinkedIn would probably notice that uh, there's times where I'm pretty active on it, and then there's times when I just kind of go silent. I think the last couple posts I did, I said, I hadn't really posted anything clinical here for a while. It's easy to comment and weigh in on other people's posts because you just have to hit reply and put in your text and then hit send. Um, to do a case or to put up a case and say, hey, what do people think of this, or what are the residents more for the residents and things. You got to collate the pre-op X-rays and the intra-op and the post-op and sort of get the history right. So my residents and my fellows do help with that piece of it, but then it just comes into my phone, and I do everything from my iPhone. So I haven't even tried to do it from the computer, and I am assuming, and maybe that's a wrong assumption, that a lot of the people who are doing a really great job of it are using some of the tools on their laptop, because I think you have a little more versatility than with the iPhone. So I do what I can, and I just try to keep the content uh, relevant and positive, upbeat, and constructive. That's the big thing. So yeah, that's how it goes, and so it just ebbs and flows with what my timeline is and how much time I have to spend on it.
Now, have you thought about expanding past LinkedIn, or do you think it's gonna stick with LinkedIn?
I don't know. I mean, I think uh, I'm trying to figure out, why I would do that, and my friends joke because they'll say, "Oh, you're a social media influencer," and I said that's really funny to me because about 10 years ago I watched this TED talk where they were talking about like the millennials and sort of the generation behind us, and a large percentage of them, when asked what they wanted to be when they grew up, it was a social media influencer, and I didn't even know what that meant. So I was just like, "What is that?"
And now you are one.
Well, I struggle to call myself a social media influencer. I do get people who reach out to me and say, "Hey, I love what you're doing on LinkedIn." And some people like you're really. So I've had someone say spicy. I've had someone say, uh, you'll say whatever, and I do kind of push back on that a little bit because I'm never trying to be facetious or out of bounds. It's usually, hey, you did this. Have you thought about that? And it takes quite a bit of courage to have someone put a case up for the whole world to see. And I mean, Errol, when we've done courses together, you always offer your attendees to bring a case of theirs to share and to say what they did or show what they did, or even one that they maybe have questions on and they want the panel and the rest of the room, kind of the peanut gallery, to weigh in. And I'm surprised at how low that participation is. I mean, do you have a opinion about that? Because I think it takes quite a bit of courage to be able to just kind of lay it out there and be comfortable with the fact that we are human and accept the fact that we're human, and you may do something that other people don't agree with. You may do something that's less than perfect. But I think that's the charm sometimes of some of the faculty that I've worked with uh, these these types of things, because I have a very easy time getting up and saying, "Hey, this is where I think I could have went left when I went right." And I learned that in residency and in training coming up and M&Ms, and we did radiology rounds twice a month where I trained, and it was a lot of just doctors just kind of arguing with each other about what was the right thing to do, what wasn't the right thing to do. And what you learn from that is if you just absorb that and kind of take in everything that everyone is saying, you can really take a lot away from what you've done and how you evolve as a surgeon and things that you do. I constantly learn new tricks and pearls and tips and things when I do these courses and when I talk to other surgeons such as yourself, people who have different ways of doing things. And if you don't put it out there and you don't expose it, no one's gonna be able to really weigh in on it.
Yeah. No, so I did one of my fellowships in Australia, and they really opened my eyes, and they called me out, or me as the general American. They called Americans out, and they're like, "We are sick of going to your courses where you choose your best X-rays in your best cases, and you put them up and just say." Look, everybody, look at how fantastic of a surgeon I am. And then you sit down and no one learns anything. When they have conferences, they put up their disasters. They put up their tough cases and they actually ask for advice or they show their learning points. And I've taken that to heart. I'm the person that's up there. I don't just show my good stuff. I say, hey, if I'm teaching a course, I say, hey, learn from my mistakes. This is where I went left, where I should have gone right. And don't make my mistake. I made it for you. And I think that's so important. And so, yes, I do think that if you're getting up there and you're showing that case, that does take a lot of guts. But I also think that sometimes it takes a lot of guts to say, I don't agree with what you did. And so, sometimes it takes that balancing act to very gently and politically be able to have those debates of, sometimes there's just a different way to skin a cat, or sometimes that might have just been the wrong thing to do.
Yeah. I think that's 100% right. There's two sides of the coin. One is putting it up, and I agree with you. There's always, and we all know, like in our circle or sphere of where we go, we know the guys that put up the stuff, and it's always, hey, look at this awesome case. My favorite is the guy who's like, oh, this is a nothing, but you shouldn't be doing it. You should leave it to the experts like us. And that's never been my goal, ever since I started educating other doctors, and when it came to residents and fellows and doing consulting stuff where I was teaching courses for companies. My goal is never to try to elevate myself into something that other people couldn't do to make myself feel better. It was my job was and is to convince a surgeon who maybe hadn't taken the leap that, hey, you can do this if you get the proper training, if you look at it the right way. You have support. Every course I've ever done, I've offered uh, the entire room. Here's my email, here's my phone. You can. I'm happy to help on outside of this. Not assuming that everybody wants to do it my way, but just saying, this isn't for show. This is literally, if you want to take the leap and you want help doing this, give me a call if you feel like I have something to offer, and I'm happy to help someone do that. Because I think it's more impressive if you can get someone who's maybe not there to get there, and that way, like, let's say you are the best surgeon on the planet, or you're the smartest doctor, you're the best one in the room, or whatever. How many patients can you touch a year, right? I mean, you can only do what 24 hours a day, 7 days a week, 365 days a year allows. If you can put those skills into someone else's arena, someone else's hand, and get them there so that it's safe and effective and it's good for patient care, how many more people have you helped, right? Just by helping the person that's helping them.
Absolutely. Now, have you had negative comments on your LinkedIn? Have you had to deal with negativity?
Oh
You're
yeah,
like,
and
yeah.
I mean, the one thing I do know about social media, because I do listen to some podcasts, and there's guys and gals on the podcasts, and I go around a bunch of different people who are like, I kind of like the style and how they do it. So I drive, and when I'm driving to work, that'll go on if I'm not making phone calls. And there's several people who are like, just whatever you do on social media, don't read the comments. Everybody, it's very easy. It's very easy to be rude to another human being through social media, through the internet. I find, and I think, would that person actually come up to me in a in-person conference and say, hey, what you just did there's going to end up in an amputation, right? And I've actually had that. I do quite a few total talus salvages for failed total ankles, and there is a group, that there are people who, and there's people who have uh, different ways of expressing. There's people who are skeptical, which is fine, and that's absolutely what it's supposed to be, right? We have to prove that what we're doing is working. You have to have good reason for it. Uh, we're never experimenting on other human beings and just kind of throwing caution to the wind. you have to have good reasons. And usually what happens in these cases is you have someone who's literally facing an amputation and they say, I don't want that amputation. And you say to them, well, if we try this, understand you could end up right back here in an amputation, and you're back to where we are today, only you've gone through the pain, suffering, recovery of more surgery. And some patients are like, I don't care. I want to try something new. I want to try something different. And that's how these things are born. And that's what happens. And it's easier for me too, because as a designer who brought up some technology, some newer stuff. I remember talking about it in the early days, and some people didn't understand how it worked, and some people didn't think it was going to make a difference. And you had to tell a patient, like, this is why I'm going to do something different. You have risk factors. You're this, you're that. You're a salvage case, right? Save it for a salvage case, and and those start to build. And if what you're doing is working, then you get confidence every time you get a successful outcome and another successful outcome and another successful outcome. And that newer technologies, newer techniques, they should take time to become mainstream. There are things that I've tried in the design world, the design surgeon world, that we abandoned. We tried some and we said, you know what,
Sure.
this is really not producing much better results, maybe even inferior results. And if you figure that out, you have a duty to kind of abandon that regardless. And I've done that in the consulting design space too, where financially we'd love to go out and say, hey, this thing works great, and get people to use it, but that's never how we did things. So you have to be willing to do that as well. So I think you just have to be honest with everybody. And if you expose that authenticity of, here's what I do that doesn't work, right? We were talking about that. I mean, when you get up, Ariel, and you say, hey, here's one of my disasters, you immediately expose yourself. And then the next time you say, but this is something that I do that works really, really well, people are going to believe you. If you get up
Yes.
and everything you do works perfectly and you never have complications, and you're this and you're that, and it's just like, no one believes that ever. And you hear that too. So I have people who have thrown bombs at me with some LinkedIn stuff, and I'm okay with that. It's usually I'll respond with something constructive, like, hey, okay, then how would you have done it different, or why are you saying this, right? And then there's some people who just repeatedly are just, they don't really offer much to the conversation other than throwing bombs. And so then sometimes you'll snip back and say, okay, whatever. And then other times you just kind of move on from them because they don't want to engage, right? Similarly, there's people who everything works great, and you question sometimes the authenticity of that, and you try to engage that, like you said, as the other side of being a constructive criticizer and saying, well, did you think about this or that? And I've tried that and I've had problems with it. And sometimes someone's really rigid in sort of how they describe things. I've had people just kind of stop responding too, where it's like, all right, well, you're a pain, and you're challenging me, and I don't want to deal with that, so I'll just disengage. And that's fine. You let them do it, because that's just how it goes. And so you kind of figure out in your community, at least our LinkedIn community, who the players are, who are the people that are willing to engage, who are the people that are willing to put their authentic stuff out there. And if you say, hey, did you think of this or that? Oh yeah, I didn't think of that, but I could have done this. And so that's when you start to develop, at least what I feel, what we've started to develop is sort of a circle of people that are not an echo chamber, but also will engage in an authentic way. And so that's how you're tagging people. I had to learn how to do that, from some of my younger uh, residents and fellows. I'm very, very amateur with this. I just put out the content that I put out because it's fun to educate, and that's what we like to do. And hopefully it's working. And that's kind of it in a nutshell.
But I think that's really wonderful. Like that, what a great way to respond. I mean, from such a negative response. I mean, you're posting a case, and for someone to come at you that way, to be like, okay, well, then how would you have done it? That's only inciting conversation. That's only inciting education, and putting someone else on the spot, saying, okay, how would you handle this? I think that's a really brilliant way to address that. And second of all, I've learned way long ago to never take any x-ray in a vacuum. We are the only specialty, right, where someone can radiographically take something and look at it and judge our work. You can't do that for colorectal surgery. You can't do that for cancer surgery. You can't do that for anything else, right? That's all internal. Someone can just snapshot an x ray and say if we are, quote unquote, a bad or a good surgeon, if we did a bad or a good job, when they have no idea what the conversation was, what the patient compliance, what the aims of the surgery was. So I think that without the context of the patient, with the preoperative plan, the preoperative, consultation and the expectations, an x-ray in isolation really doesn't mean a lot. And it just doesn't.
Yeah, I mean, that's 100% right. I think we're definitely on the level when it comes to how you think about this and how I think about it. I did have, there's one person on LinkedIn who was like, that'll be an amputation in 6 months. And typically I follow my cases and I follow my patients. And one time I replied and I said, well, this patient's actually out 2 years successfully and still doing well and happy with this. Should I call her up and say, hey, you're 18 months overdue for your amputation. Let's go ahead and schedule it. Something sarcastic and funny, not to be a jerk, but just to like put some humor and levity into it. And that's when I get to be like, oh, you're spicy. And it's like, well, what else am I going to say? Like, am I going to get down and dirty and say something rude? I mean, I'm human. I probably could be prodded to do that, but you try not to. And then to your point, I have friends who do medical legal stuff, and some of them they don't specialize exactly in the subspecialty that I'm in, and they'll send me like an x-ray and say like, was this malpractice? And I'm like, uh, I need a lot more context than two views of an x-ray, right? What was the, like you said, what was the conversation with the patient? Did you read the chart? Was the patient compliant? Does it not look like a perfect x-ray? And I know I mean, I did this MIS tournament, for the Lure Expo that Innova sponsored. And when they called me, I said, I'm not an MIS guy. I mean, I do minimal incision, which means the smallest incision I can do. It really, I've started paying a lot more attention to it. But I, when this was first becoming popular, you'd look at these X-rays and you'd say, this is crazy. And I had docs say, this has got to be malpractice. Prominent people in our field, that this is malpractice. And I go, well, I don't know, right? I don't know what the patient. Maybe the patient had a burn on their skin, and this is like the best way to get this deformity somewhat corrected. And you and I both know that you'll have some patients that have just hideous looking X-rays, and they're the ones who send you cookies every Christmas because they love it.
Yep.
And you're just like, yeah, you're just like, all right, I'll just stop taking X-ray of that until you start complaining again because I don't like looking at it. But they're some of the happiest patients you have. And I've seen patients too. Uh, I'm not, I tell all my patients, I don't do cosmetic surgery. So I don't do cosmetic foot surgery. My forefoot patients, if your bunion doesn't hurt, if your toes aren't bothering you, I'm not your guy. If you want it straight, I'm not your guy. I tell patients, I'll make it perfectly straight on the operating room table. That's how we'll leave. But I can't tell you what will happen 6 weeks from now, 6 months from now, 6 years from now. I tell patients with toes, like it's like balancing a marble on a needle. There's so much motion going on there, and there's so much stress that goes across it. I can make it straight on the table, but how your foot functions when you're in a shoe and when you're in a tennis shoe or a flip flop, I don't have that insight. So I've had patients come in from other doctors who've had like perfect looking X-rays, and they're unhappy, and I can't figure out what the problem is. So that's the thing when we say we treat people, not images, right? X-rays and MRIs and CT scans, they're all things that help us confirm what we think our diagnosis is going to be. They're an objective test that helps us rule out things and rule in things, but they certainly don't tell the story about patient satisfaction, function, and pain level.
Absolutely. Speaking of patients, great segue. Do patients follow you on LinkedIn or other social media? Like, do you accept those friend requests, or do you not?
They do. Some of them find me. I'm so I, One of the things too, when I was in my smaller niche private practice, I never bothered with reviews and things. Like people could be calling me an axe murderer. I wouldn't know. I just never did this. This sounds like BS, but it's legit true. You guys can do your homework on me. I just don't. I just never really took time to do that stuff. Now that I'm in the big ortho practice, there's an old department that does that. They want feedback, and they do reviews, and it's how you look at like a doctor on a hospital, and they have 700 reviews. It's like, I'm like, I've treated over 700 patients in 20 years, but they don't go online, giving me 5 stars. The old saying, right, is that uh, someone's much more likely to go and complain about you online than take someone who's happy is not going to go out of their way to tell everyone how great you are. It's much more motivating when you're upset about something. And so one of the things that happens is they kind of collate that, or they kind of go put it out there like, hey, can you give us a review or whatever. And and as I've started learning about that side of the business, I've also started learning that patients do look us up, and they do use the internet. And don't assume that if they're older than me, I don't assume anywhere that if they're older than me, they're not really doing things on the internet. I've had patients come in. I go, well, how did you find me? Oh, well, I looked up online and you have good reviews, right? Okay. So then you start going, well, people do pay attention to this. And so there are people who are patients who are older, who are savvy. And I do have a couple patients. One in particular, he's a big he was a big total talus, total ankle revision after he had two failed attempts. And he's doing great. He's now, gosh, he might be pushing 4 years out, 5 years out. And I just saw him the other day for an annual X-ray, because I do, like I said, I do follow these. You can't tell me you don't have complications if you discharge your patient after 8 weeks after surgery. It's like, well, you didn't see it, but I do try to follow these patients, particularly these ones that are more complicated, to just see if anything's going bad and to learn and to head off any problems. And he came in for his annual X-ray. He's like, "Hey, have you put me on LinkedIn?" He loves it. He's like, he saw himself on LinkedIn. He saw his X-rays on LinkedIn. He's like, "Have you put me on LinkedIn lately?" I said, "Well," I said, "I don't really have a reason to, but do you want me to tell everybody you're still doing great?" He's like, "Yeah, that'd be great." So yeah, I mean, I don't know how many actually follow. On LinkedIn, you have these many followers, and I don't even do like the stuff where I can analyze all that, right? I have the basic account. I put things on. I have conversations with people. I've had people reach out, but I'm assuming, and well, I know that at least one and probably other patients do follow you. And I do know, actually, I do know another patient too who was a very complex salvage, and she's also one who I've been really close with, and her case was, probably, I don't want to say 10 years ago. Yeah, it may have been 10 years ago where we finally got her aneurysmal bone cyst cured and got her active after just a devastating course of care, and multiple conversations about amputation. And when someone like that says, "Doc, I believe in you, and I know this isn't you, this is my body. Can we try something else?" And you have that reasonable patient. Aaron, I'd love your opinion on this. Like, at what point do you say, okay, I mean, these patients understand that you're providing everything you can, and you get those patients over the goal line when, if they're savvy, that they tend to follow. They tend to drop a note every once in a while and say, "Hey, how you doing?" And that's really nice. That's really nice to hear, and it's encouraging. But what's your metric for that patient that is just nothing's going right, and it's not you who's having the problems. You put the screw in the proper place, everything's positioned, everything's great, and something doesn't heal, and then it turns into another thing and another thing, and you sent that patient to 3 or 4 of your colleagues who you trust to say, "What am I missing? What else should I be doing?" And they go, "We have nothing else to offer," and the patient comes back and says, "No, I know it's not you, I want you." Sometimes we have to develop some self-restraint, but it's hard when that patient says, "I want you to try something else," and you feel like there's a chance that it can work, or better than 50-50 chance, right? And I'm talking about cases where sometimes it started out simple. And I have a case where a patient, and I've presented this case at conference too, so it's not even a secret, but I've had a patient that just sprained both of her first MPJs, falling on the steps in her garage. Low impact energy injury, low impact injury. Uh, the one side, we treated her conservatively. The one side did fine. The other side just devolved into a mess, and to be real, long story short, I mean, she ended up with a TMA amputation because things got infected. We didn't do surgery, then we did surgery. We did joint sparing surgery. That didn't work. That got infected. Then we tried to do a fusion. Then we did a lengthening with a bone graft and a fusion. I mean, and then we did we got all the way into like printing technology. And if the infection hadn't been there, the pad that she had, I've had a couple other patients since then. It worked, or before and after. But we really got to the point where I said to her, "I think you'll do better with a transmetatarsal amputation. I really do." And it was hard for her to accept that, but she had to kind of go through that process of all this technology. And she was a university researcher, so she was very bright. She was very very sophisticated in what we were talking about. And to this day, I get, "Hey, thank you so much for all you've done." I mean, we feel like failures because we couldn't make something work, but she now is much more active in a much better place. And sometimes you just have to tell someone, "This is the end of the line. I really don't have anything else to offer you." And so those are the kind of things too that I like to see on social media, on LinkedIn, and I think that's good for patients to see that, because some of the patients that are in that rut where their doctor is doing everything that can be done and their doctor is doing a good job and they're just not getting good results, uh, it's nice to know you're not alone. Just like as a doctor, as a surgeon, when we have complications or we have a tough case, I always really took solace when I would go to conferences, a young surgeon, and the guys that were authentic, who would put their complications on the screen. You'd say, "Oh, I'm not the only one who's ever had this happen," and it just kind of settles you a little bit inside, and helps you get out of bed, get back on the horse again.
Yeah. No, absolutely. I mean, I think not only does it give solace to the patients, you took the words out of my mouth, it gives solace to us. We all have that one patient that we can just think about, and we know that we did everything right. And in hindsight, we would have done everything the same way every step of the way. And it still did not come up with an optimal result. And those are hard. That's the hard part of our job. But when we go to conferences, and when you and I get to teach conferences together and we get to have these kind of heart to hearts about it, it does help. It makes it less isolating, makes it less alone. And if you're not teaching conferences, that's where this social media kind of influence can be really helpful. As we had talked about before, I have like no social media when it comes to work. I have a Facebook profile that my mom follows and makes sure that some earthquake 800 miles away didn't affect me, because she thinks that California is a state this big. But that's my social media influence. So I never have really understood it, but this makes sense to me. Like, this isn't like, some influencer on Instagram. This is what I think about it. This is sharing of ideas. This is sharing of cases. This is meeting of minds. So, I think it's really cool what you're doing.
I think, having taught a course with you, you should be doing it. You really, I mean, because you are authentic. You really don't have a problem getting up on there. From what I saw, I mean, and I remember the first time we met, and you were like, "Hey, man, I looked at your stuff, and you put this crazy case up, but then it ends up in a save, right?" And I was like, "Well, this isn't it's a tough case course, but I guess we read the memo a little differently, and if you
I want to,
want to
I
if
want
you
to,
want to
I
dance,
want to, I want to, I want to backtrack to let everyone know. So we were supposed to do. It was a good, a bad, and an ugly case.
yeah,
And
right.
so I go up there and I post like a disaster case, and Doug goes up there and posts this awesome case that he did. And he's like, "Well, I mean, it was ugly because it started ugly. And then I'm just an awesome surgeon and I did a great job with it."
Well, you'll never hear me say that. One of the things I tell my residents felt all the time is that, your ego will get in the way of making you the best surgeon you can possibly be. That's something that's always on the table. Humility is something that you have to have. And my grandmother Angie, who would be 96 years old, was my favorite person in the world, and she was just a gem of a human being, and she taught me very early age. She had a saying, which is, "Doug, if you don't learn to laugh at yourself, the whole world will be more than willing to do it for you." And that wasn't just about like sarcasm and laughing and having fun. And people who know me know that, like, my love language is sort of teasing and banter and making fun, and so if I so that's sort of like if you're comfortable enough with someone to say, hey, let's poke fun at each other, that builds a bond. And so to that end, I mean, uh, that my point of that case was sort of it's ugly, but here's how you can use this technology. Because I took it as like, hey, I'm teaching a course for this company. I want to display this technology, how you can sort of get out of this. If we went to like a straight up complications course, right, where it's like, no, no, we want to see one that you just could not get back, right, and because the people in the crowd, the doctors that are there, the surgeons that are there, the young surgeons that are there who don't have the 20 years under their belt, they need to see that these things happen, and they need to see that that as long as you did everything you could, as long as the patient had consent, as long as you gave consideration, then these things are, you're not really held too terribly accountable to it, because there's what we control, there's what the patient controls before and after surgery, and then there's the third part of that, which is what nobody controls. And when that third guy that gets in the room and decides to take over, that's when you feel the most helpless. And we're expected to know everything, we're expected to fix everything. And one of the things you have to learn to be able to do is to tell a patient, I don't know, and I'm not sure where we're headed, and we're kind of going into uncharted territory, and if you want to go there with me, we can do that. The thing that requires, though, is it requires spending time with that patient, sitting down, maybe making a special appointment with that patient in your 15-minute a day slot clinic, to say, come at the end of the day and we'll sit down and we'll talk as much as you want about this until you're comfortable. And I'm going to tell you the good, the bad, and the ugly of what your options are, and let you be the arbiter. My number one job for you as a patient is to not let you make a bad decision, right? If you ask me for something that I know will not work, then I will say no, and you will, if that's exactly what you're set on it, you'll have to go somewhere else. And I can give you a real world example of that. I mean, I don't really buy into the unblocked fresh frozen talus for OCD. It was very popular 20 years ago when I first started, and I did a bunch of them, and I did them. If you looked at my X-rays, you'd say, well, these are pretty good. And there's just literature they don't incorporate. They're not really good for patients who are young. They're not going to last unless it's small and you're trying to bridge something, right? Or the patient's really old. But even now, I think back when I was doing that, and I did that on some older patients, I would probably just do a total ankle now, because
Yeah.
we learned to trust that system better. But I would ask you this question, which is, um, I had a younger patient come in who saw a doctor who was a younger surgeon, who said, "Oh, we'll just take your OCD out and we'll put this plug in." And he had a really, really bad, I'm talking like a 2.5 centimeter lesion that was through subchondral plate. And he just literally walked on it for years as a workaholic. He just kept putting up with it, putting up with it. And then he finally said, this is it. And he was in his, early 40s. And so one of his opinions was, hey, I'll just take this piece of frozen talus and put it in. And that's what they wanted. They came in, him and his wife, they wanted that. And I said, listen, uh, I won't do that on you. Not because I'm a mean guy, not because I don't like you, not because I don't want to help you, but because I've tried it. It's not ideal. You really need to consider a fusion or a replacement at this point, and then go down the list of why you would take a fusion over a replacement at that age level. And as you know, we've dropped the age considerably in terms of when you have special circumstances. It's not inappropriate at all to give someone a total ankle replacement, particularly because we have the capacity to salvage the stuff that goes sideways much better than we did 20 years ago. I mean,
Sure.
I know you're very trained on total ankle replacements, and so I would love to know your opinion about, what's the cutoff for age when it comes to ankle replacement.
I've I would say even over the last 5 years, I've dropped that age a lot. But it's there's no one age. It's what do you wanna do with it? Are you a thin rheumatoid who wants to walk? Well, that age is gonna be a lot lower than are you a heavier set athlete or someone that still wants to play pickleball and be active. Those are just two different patients to me. So I don't have an actual number. But I think we have very similar philosophies. And the way I feel of myself as a surgeon is I provide information. I give you information. Like, this is what, this is what a total ankle looks like. This is what a fusion looks like. This is what an oats procedure or, using a fresh frozen talus looks like. And these are the risks and benefits. And these are the outcomes in the literature. And these are my personal outcomes that I've seen. Now you're in the driver's seat. Now I feel like I've adequately prepared you and given you that information. Now you get to make that decision, and I can help you make that decision. But really, what I am is I'm an information provider. I'm here to give you that information. And it seems like you do things pretty similarly.
That's perfect. I couldn't agree more. I do tell patients, what is the word doctor in Latin? It's teacher. That's
I
all
was
it
like,
is.
I have no, I was like, I don't know.
It's teacher. Doctor is
Thanks.
Latin for teacher. And so doctorus is you're a teacher, you're a professor, a teacher of a certain discipline, right? A PhD is a doctor of philosophy. It's a teacher of philosophy. An MD is a doctor of medicine, right? And so that's something that I will sit with those complicated patients and say, I am not, the surgeon, and one of the things I love is when you've been doing it long enough and you decide early on in your career that I'm going to go for the slow dime and not the quick nickel, right? I'm not going to operate on everybody who I can talk into having surgery or whatever. You're going to build that. I was very cognizant in my early career. There were bumpers in my career. One was when I first started my private practice, and a lot of young practitioners probably don't see this pressure because not many of us are going out and hanging a shingle and starting a practice and starting from scratch and trying to build a reputation, and not just the community at large, but also the medical community, the referring community around you. Most people are now getting plugged into big systems where they already have that. You're being hired to do this, right? And we already have all this
Right.
work, and it's just going to turn the spigot on and off you go. Um, I had to learn that I don't want to do anything crazy and have the referring doctors be like, this guy's a nut job, and don't send patients to him. You wanted them to be like, hey, this is the guy I want to send people to. Couple things for the young doctors out there that are listening. The people that come into your office early in your career that are just crazy and they're difficult to deal with, and you feel like you have to put up with them because you don't want them going back and telling the referring doctor that you're a bad doctor. Here's something I learned. That doctor knows that they're difficult also, right? That's something that took a while for me to figure out, but it kind of kept me in sort of a tight space. And so sitting down and explaining to patients, this is what we can do. And like you said, just giving them their options, but taking the time to make sure they understand their options fully so that they can make the decision, and then putting a guardrail on that says, if you ask me for something that I cannot deliver, then I'm going to say no. And I had a patient years ago, 20 years ago, 15, 20 years ago, I probably did like 3 ankle fusions for every replacement at the time. It was still gold standard. And I'm not talking about my diabetic population, right? And then if you take away my diabetic population, that gets way more fusions than replacements. It's more like 3 to 1 the other direction, right? 2 to 3 to 1. I don't know where
Sure.
you're at with that, but I had a patient came in and she was like a competitive barrel horse rider, and she was 53 and she wanted to ride horses, and I said to her, I really don't feel comfortable putting an ankle replacement if you're going to engage in that activity, because you're going to you're going to dislocate it sooner or later. And now you've turned yourself from a successful fusion patient that you'd have to put enough energy to break the bone, right, on the horse, which then it wouldn't have mattered what the surgery was, to now you're in a limb salvage situation, and you hear the whole, well, I don't want to limp, and I don't want to walk like a zombie, and not people don't do that when you do a fusion properly. I show videos. I literally pull up my computer. I have a lecture on this. I teach this to surgeons. Here's the mix and match game. I have an X-ray of a TTC fusion. I have an X-ray of an isolated arthroscopic ankle fusion. I have an X-ray of a total ankle up there, and then I just show 3 videos of all one gender walking, and I ask my patients, who's the fusion here?
Who's what?
And they can't
That's
tell you.
great.
Yeah, they
Yeah.
yeah, they can't
Can't
tell you.
tell.
So
Yeah.
she but she didn't like my answer. So, and I said to her, if you want this bad enough, you'll find somebody who's either inexperienced enough who wants to do it, who will try it on you, or somebody who's arrogant enough to think they can make it work on you, and you'll get it if you shop enough. And she never came back, but that's okay. I had to learn to be okay with that, and that was sort of missing out on the case to build the reputation that says when this person says to you, "This is what you need," it's what you need. There's no agenda. There's no ulterior motives there. There's nothing else going on. And when you get to the point in your career where you've done so much for so long, the whole like doing the surgery is not that exciting anymore, right? It's more the patient interaction, the service to the patient, and the gratification comes from that patient coming back and saying, "Wow, my life is much better because I got to work with you." And it's not the technical aspect of the surgery anymore. It's another saying I have, which is, when we go to the airport, we expect that the pilot knows how to land the airplane. Right. If someone walks into your office, they expect that you know how to do the surgery, that you can do it well and be good at what you're good at and do
Of
what you're good
course.
at and be good at what you do. And so that part has really infiltrated the last 10, 12 years of my career too, because you kind of get comfortable in your own skin. You kind of stop caring about what other people think, and then all you have to care about is how well you service that other human being that walked through your door. And I think that's a really nice place to be. I told you I'm a hunter, right? I like to be out. I'm an outdoorsman. I like to hunt. And uh and there's this whole like thing called the evolution of the hunter, which is the hunter first just wants to fire their gun or their bow and arrow or something. They just want to get out there and do something, and then so I got to kill something, and then so I got to kill a lot. I got to kill a big thing. Eventually you evolve, and I think surgeons are no different. We eventually evolved to the point where just being out in the woods, just being out in nature, and just being in the environment and absorbing that is that final stage of the hunter's evolution. And I think it's not dissimilar with surgeons. Just being of service to another human being, whether that's giving them an injection and making them better, ordering physical therapy or inserts or a brace or something. You get that satisfied gratification when that patient comes in and say, "Hey, you helped me and it wasn't difficult and I didn't have to do all this crazy stuff." There's a lot of gratification in that also.
I completely agree. Doug, it's always a pleasure to talk to you. I always learn something every time we hang out.
I feel like I talk too much. I'd like to ask you a bunch of questions, but I know that's
No,
not today. Maybe
not
maybe
today,
next time.
sir. Maybe
Maybe
next
next time I
time.
get to you. Yeah.
I feel like you've inspired me to maybe dust off my LinkedIn page and look into it a little bit further.
I would love to see you on there because I'm going to tell you, I'm certainly no social media expert, but I am on that, and I do think we have a pretty good foot and ankle community, mixed bag of guys. There's always the outliers, the bad actors, but they get kind of ignored. And the people that are really being constructive and really doing good work and doing great stuff, it's a very supportive community. And I'm probably really a small fish in terms of that community, but it's great to be a part of it, and you would fit right in. So I would highly encourage you to get on there and get a profile and start weighing in, because you're always thinking outside the box, and you're always thinking things through, and you're really good at giving back good feedback.
All right, I'm going to take a peek. Well, to all of our listeners and viewers, thank you so much for joining us today, and we look forward to seeing you the next time.